All right, let's dive straight into this rapid-fire explainer covering high-yield pediatric surgical clinical profiles. We're going to move incredibly fast to lock in these clinical patterns with absolutely zero distractions. Let's go. A 12-year-old child is brought in by her mother because of pain in the right hip while walking. She's also experiencing pain in the right knee joint. On examination, the right lower limb is shortened and externally rotated, and there's no evidence of any recent infection or trauma. So, what's the probable diagnosis here? Option A, slipped capital femoral epiphyses. Option B, Legges-Calves-Perthes disease. Option C, posterior hip dislocation. Option D, extracapsular femur fracture. Or Option E, fractured pelvis. The correct diagnosis is Option A.
Slipped capital femoral epiphysis is the correct answer. The core reason here is a mechanical stress fracture that develops straight across the vulnerable hypertrophic zone of the growth plate, which causes the metaphysis to literally slip. You definitely need to remember the referred knee pain pearl here. The metatarsal or obturator nerve pathways project that hip pathology as isolated knee pain. Also, keep in mind the bilateral potential in 25% of cases, and the primary risk of delayed stabilization, which is avascular necrosis.
What is the most common type of syndactyly? Option A, middle finger, ring finger. Option B, ring finger, little finger. Option C, index finger, ring finger. Option D, thumb, index finger. Or Option E, index finger, middle finger, ring finger. Option A is the correct answer.
Middle finger, ring finger is the correct answer. This actually results from a failure of programmed cell death, or apoptosis, to separate the digital webs between the 6th and 8th weeks of embryonic development. Let's look at the frequencies. The third web space, between the middle and ring finger, is the absolute most common at roughly 50%. The fourth web space is about 30%, the second web space is 15%, and the first web space, the thumb to index finger, is the least common at just 5%.
In the upper limb, which web space is most commonly involved in syndactyly? Option A, first web space. Option B, second web space. Option C, third web space. Option D, fourth web space. Or Option E, third and fourth web space. The answer is Option C.
The third web space is the correct answer. Now, while the first web space is the rarest, it's actually the most functionally severe because the thumb and index finger have vastly different lengths and arcs of motion. Binding them together causes severe growth restriction and hand dysfunction. Let's hit 4 related deformity pearls really quickly. Cymbrichydactyly is linked to Poland syndrome. Polydactyly is the presence of an extra digit. Camptodactyly is a fixed flexion deformity, and clinodactyly is an abnormal angulation in the coronal plane.
Clubfoot has deformity in how many planes? Option A, 1 plane. Option B, 2 planes. Option C, 3 planes. Option D, 4 planes. Or Option E, none of the above. The correct answer is Option C, 3 planes.
Congenital talus equinovarus involves structural malalignments across 3 distinct planes. Let's break down the CAVE anatomy acronym. That stands for cavus, adduction, varus, and equinus. For treatment, the highly effective Ponseti method uses a specific sequence of weekly serial plaster casts to correct the deformities in that exact sequential order. So that's cavus first, then adduction and varus together, and finally equinus. This whole process is followed by bracing maintenance until age 4. A patient comes in complaining of no testes in the left hemiscrotum and a mass in the left groin. On examination, the left half of the scrotum is underdeveloped and the left testes is not palpable. However, there's a 3 by 2 centimeter lump in the left inguinal region. Which of the following is the most appropriate next step for this condition? Option A, ultrasound scanning. Option B, orchidopexy. Option C, laparoscopy. Option D, excisional biopsy of inguinal mass. Or Option E, MRI of inguinal mass. Option B is the most appropriate next step. Orchidopexy is the answer. A clear physical examination by an experienced surgeon completely overrides routine imaging, dictating a direct path straight to surgery. If you have a palpable intracanalicular mass, that leads to a standard orchidopexy. If it were non-palpable, your next step would be a diagnostic laparoscopy. And the crucial exam pearl here regarding timing is that this should ideally happen between 6 to 12 months of age.
A 4-year-old child is brought to the hospital by his parents with a complaint of a right-sided undescended testis. On examination, the right testis is impalpable with an underdeveloped scrotum. A laparoscopic examination shows blind-ended gonadal vessels. What's the next best step? Option A, do nothing and come out. Option B, exploration of inguinal region. Option C, exploration of scrotum. Option D,
orchidopexy, or option E, none of the above? The answer is option A. Do nothing and come out. Visualizing blind-ended gonadal vessels and a blind-ending vas deferens is definitive proof of monarchia, also known as vanishing testis syndrome. It literally means there's no viable testicular tissue left due to a late intrauterine vascular accident, something like torsion. This completely eliminates the need for further exploration. Looking at the management matrix, excision is only indicated if a dysplastic remnant is actually found.
A child presents with bowed legs and X-ray findings of epiphyseal widening. What is the basic pathology in this patient? Option A, increased osteoclastic activity. Option B, decreased osteoclastic activity. Option C, defective bone mineralization. Option D, defective renal absorption of calcium. Or option E, none of the above. Option C is the core pathology here.
Defective bone mineralization is the answer. Rickets is most commonly caused by a vitamin D deficiency, which triggers secondary hyperparathyroidism. What's really interesting here is the compensatory osteoblastic activity driving up the alkaline phosphatase, creating a very specific biochemical profile of low calcium and high ALP. You'll also see radiographic epiphyseal widening and metaphyseal cupping, alongside physical signs like the classic rachetic rosary. An 18-month-old male patient is brought in by his parents complaining of an empty left hemiscrotum and a mass in the left groin. On examination, the left half of the scrotum is underdeveloped, the left testes isn't palpable, and there's a 3 by 2 centimeter swelling in the left inguinal region. The right testes is perfectly normal. Which of the following is the appropriate treatment for this patient? Option A, orchiectomy. Option B, urgent orchidopexy. Option C, orchiectomy with placement of prosthesis. Option D, excisional biopsy of inguinal mass. Or option E, orchidopexy a few months later. Option B is the urgently required treatment.
Urgent orchidopexy is correct. This patient is well beyond the ideal 6 to 12-month window we talked about. Prolonged heat causes progressive germ cell depletion. Leaving a cryptorchid testis uncorrected drastically spikes the malignancy risk profile, making it 15 to 20 times higher. Bringing the testis into the scrotum optimizes growth, and crossing this atrophy boundary is absolutely crucial because it allows for future routine clinical palpation and self-examinations.
An 8-year-old male child is brought to the outpatient department by his parents complaining that his right testis is going in and out of the scrotum. On examination, the scrotum is well developed. What should be the best strategy here? Option A, orchiectomy. Option B, orchidopexy. Option C, observation with follow-up. Option D, beta HCG levels. Or option E, none of the above. Option C is the best strategy.
Observation with follow-up is the answer. This specific presentation points straight to an overactive cremasteric reflex. A well-developed scrotum perfectly differentiates a retractile testes from true cryptorchidism. True cryptorchidism features an underdeveloped scrotum, which is often referred to as the scrotal sign. Observation is absolutely key here to monitor for an ascending testis, where the cord literally shortens over time. An 8-month-old boy is seen by a pediatrician for the very first time. The physician notes that there are no testes in the scrotum. Which of the following is the optimal management for bilateral undescended testicles in an infant? Option A, immediate surgical placement into the scrotum. Option B, chorionic gonadotropin therapy for 1 month, operative placement into the scrotum before age 2 if descent hasn't occurred. Option C, observation until age 2. Option D, observation until age 5. Or option E, no therapy. Option B is the optimal management plan.
Chorionic gonadotropin therapy for 1 month is correct. Let's quickly trace the logic of the HCG challenge. Step 1 is to administer the test to rule out complete anarchia. Step 2, if testosterone rises, it means functioning testes are present. Step 3, if there's no descent after 1 month, an orchidopexy must be scheduled before age 2. Remember, a complete lack of testosterone response totally eliminates the need for surgical exploration, and prosthetics are available if needed later on.
On an antenatal gynecologic ultrasound, right-sided hydronephrosis is detected. Postnatally, the child took 1 feed, and the attending nurse notes the child has passed urine 1 time. What should be the next step? Option A, do nothing. Option B, repeat scan after 1 week. Option C, DJ stenting. Option D, percutaneous nephrolithotomy. Or option E, none of the above. Option B is the correct step. Repeat the scan after 1 week. The pathophysiology here is most commonly a UPJ obstruction. Early scans in the first few days are actually super misleading because neonatal dehydration and a transiently low glomerular filtration rate will underestimate the true degree of hydronephrosis. Many cases improve spontaneously following a conservative trend.
The surgical indications are strictly limited to worsening scans, recurrent UTIs, or declining renal function.
Which of the following is the gold standard investigation to diagnose Hirschsprung disease? Option A, barium enema. Option B, colonoscopy. Option C, rectal biopsy. Option D, CT scan. Or option E, double contrast enema. Option C is the definitive gold standard.
Rectal biopsy is the correct answer. The histological reason is the complete absence of ganglion cells, which is accompanied by hypertrophied nerve bundles. Finally, let's rapidly review this pediatric timing summary table. Intussusception uses an enema. Pyloric stenosis requires a pyloromyotomy. An umbilical hernia gets observed. Biliary atresia needs a Kasai procedure before 8 weeks. And Hirschsprung's requires a pull-through. So when seconds count on your exams, will you have these definitive timing patterns locked in and ready to go?